Our next speaker is a well-established client of Real-Time Laboratories. She is the founder and owner of the Institute of Personalized Medicine in Georgia. While working in emergency and trauma centers across the country, she found that many chronic health problems, including obesity, diabetes, depression, high blood pressure, and heart problems, although treatable, can be prevented. She has witnessed firsthand the overall declining health in Americans. Over the past 2 years, Dr. Ross has worked alongside with Dr. Bredesen, treating and reversing patients with Alzheimer's disease. She has treated more patients using his protocol than any others in the world. She believes that using the proactive and preventive care rather than reactive treatments could help patients with such chronic diseases. The title of our talk today, Biotoxin Illness, a link to type 3 Alzheimer's disease. Please welcome Dr. Mary K. Ross.
Thank you. So I have an office in Savannah, Georgia, and I also have an office in Santa Monica. And over the last 2 years, my practice has taken a huge change. I have essentially been inundated with cognitive patients, and so they become a little bit of everything. They literally are your hormone patient, your toxic patient. They're absolutely everything. So I think they're really challenging, and they're also a great opportunity to utilize all of our skills. I'm going to tell you, to start out with, I have no financial relationships, no commercial interest. Just a mere doctor. And for the performance objectives, really what I want, I know this is not a conference based on cognition. And that's one of the things, though, that I think I can talk about today, sort of in light of what we're here for, and maybe shed some light on something new for everybody. So I'm going to talk about it. I want you to be able to recognize people that have cognitive problems and be able to link them with toxins and have an idea of how to start the workup, really, and how to evaluate them. This is, I'm going to tell you a personal story before we get started and let you know a little bit about me. I'm not going to spend too much time on it. My husband, Stephen, is here, and the two of us, back in 2012, had a huge problem with mold in our house. We didn't know that it was mold, so over that period of time, I became really sick and almost went on disability. I had psoriatic arthritis. I had autoimmune thyroid disease. I had all kinds of dysregulation. I couldn't sleep for 2 years. I couldn't breathe. I developed really elevated cortisol, and I developed something called Takotsubo. Does anybody know what that is? You might. Are you a cardiologist? No. So it's stress-induced cardiomyopathy, and the word Takotsubo, it means octopus pot in Japanese. That's what my heart looked like. A lot of times when I lecture, I'll show a picture of it because it's really crazy. So the left ventricle gets stunned, and that's from mycotoxins, and that's from the internal stress in my body and the cortisol going up, which you're also making adrenaline, and so it stunned my heart while I was giving grand rounds. Lovely, right? So I went to the cath lab and spent the weekend in the hospital on a monitored bed. And I've overcome all of that, but that has been a huge journey for me, and that's really made this a big passion of mine. Then I got involved with Dr. Dale Bredesen, right here. So for the last 2 years, we've been working together, and for the last year and a half, I've actually been his CMO of MPI. Recently, he sold his company, and that's all still remains to be seen, what we're going to do with that. But nonetheless, I've treated a lot of these patients, and he has had a way of categorizing, so I'm not going to give you a whole lecture on Bredesen, but suffice it to say, I'm going to explain to you some of the higher points that he has broken up Alzheimer's and cognitive problems into 5 different types, and we'll go through them. Type 3 is the toxic type. It's the one that we see related to mycotoxins often, and I've had an opportunity, I've probably treated over 300 of these patients, so I've had an opportunity to actually reverse and see people. I have a woman in California, for example, who is getting her license back. So that's pretty cool. She had the diagnosis of Alzheimer's disease, and the state is recognizing that she doesn't have it and giving her driver's license back. So when you think about the population in America, you have to think about it in terms of how many of these people, this disease is actually happening more often. So it's like an epidemic. So for example, it's the third leading cause of death in America, some people would say. And when you think about women, for women, they're actually more at risk for Alzheimer's disease than they are for breast cancer. So, I mean, that's huge. The face of Alzheimer's is changing. It's hitting younger people. When I say younger, I don't know what you all think about Alzheimer's. I used to think of everybody's, of course it's always getting closer now, but great uncle and grandfather and great grandfather. And now, you know, we're looking at people in their 50s and they have teenagers at home. So 45 million in the US will get Alzheimer's. That's from 2012, actually. This is a paper that came out in 2016. Dr. Bredesen wrote it. And this is really what caught my attention: inhalational Alzheimer's. It was really timely for me because I was going through my mold thing. He had just given grand rounds at Cleveland Clinic. Sorry for my voice. And basically what it states is that his type 3 Alzheimer's disease is the result of exposures to toxins. One of the big ones is mycotoxins. And so and a lot of this is exactly what we've been talking about today. But, you know, mycotoxins are nanoparticles. And we know they get in the sinuses and they cause all the inflammation. We know now that we can have, leaky gut. Well, we know that we can have leaky everything, right? So you can have leaky brain, so the blood-brain barrier. You can definitely have permeability. Your organs can have permeability. And we really think that this is a huge part of the problem. In Finland, the number one, they have the highest mortality from Alzheimer's. And they recently have attributed it to environmental factors. So their soil has less selenium, so therefore less glutathione. Presence of mold. They also have cyanobacteria, which increases the risk as well of neurodegenerative diseases. And women are the epicenter of Alzheimer's. They're the 65% of all patients are female. 60% of all of the caretakers are female as well. And so I think this is something that I just want you to understand the gravity of what Alzheimer's is doing to America, because I really think that by 2050, we will have bankrupted our whole, Medicare should be gone. And a lot of it will come from this. Think about the chronic diseases that we all deal with. Think about the chronic diseases we all know about. Cancer, for example. Cancer patients have lots of support. Nobody's really there for the Alzheimer's patients. The money is all spent at the end of life. And how many neurologists are here? Okay, good. No, I'm teasing. So for the neurologists, they see them, and all of the support is more for the caretakers. It's getting prepared for this person to die. It's getting prepared for them to go to long-term care. And so we really need to start looking at this. A monotherapy has been a complete failure. Absolutely nothing to offer to these patients. They go in, they see a doctor, the doctor says, here, let me give you some Aricept, and I'll see you in 6 months to a year. Get your affairs in order. Oh, by the way, maybe you could try a Mediterranean diet. Why not, right? And that's it. And then the rest of it is end-of-life care. And that's where the big money comes. So we need to really think ahead and think of ways that we can come up with a different way to treat it. And that's exactly what we've done. We all know that all of the drugs so far, for the most part, have targeted amyloid, right, in the brain. And we know that Alzheimer's is associated with beta amyloid. So I'm not really going to go into a huge lecture about this, but APP is what makes the amyloid. And depending on where it's cleaved, you can either get Alzheimer's or not. So you can see on the far right, it's the pro-Alzheimer's. It's the way that it's cleaved. And we actually have determined that amyloid is protective. It has antimicrobial properties. So when you develop Alzheimer's, think about this, your body's trying to protect you, not necessarily the Alzheimer's, but the amyloid part. So when you go after Alzheimer's, would it make sense to remove the amyloid when you don't know why you have it? You're just like throwing the patient and giving it to whatever it is that it has, right? So we need to look for the root cause. I am functionally trained. I have completed all of IFM's training. And really that's the approach. And the beauty of it is when Dr. Bredesen came up with this protocol, he was really using functional medicine. I don't think he was aware of it at the time. He is now. So you have to think about what your brain is trying to protect you from. And when you think about biotoxins, that's only one small part. It's not everything. And we'll go through the types, which look at inflammation, we look at glycotoxicity, so whether or not we have metabolic problems. We're going to look at trophic support for the brain. But you know, all of this is interrelated. I've never seen a type of Alzheimer's or cognitive patient that wasn't interrelated. It's lifestyle, basically, and then it's exposures. So it's genetics, lifestyle, exposures. All right. And so when we look at this, there's balance, and there's balance. Looks like my slides got moved around, actually. There's balance throughout our body, so our body always has mechanisms trying for a check and balance to avoid disease processes. So it's, you know, blastic is building, clastic is breaking down, and basically what we want to look at when we develop Alzheimer's, it's synaptoclastic. So we're breaking down our synapses. And we want to understand better how this happens. And so you can think of the other examples of what happens in your body if you develop osteoporosis, right? It's the balance between the osteoblast and the osteoclast. Same thing with anabolic versus catabolic. So these are systems, and when you start looking at it like this, it makes more sense. I don't think that we can ever focus on like one minute thing and think that you're going to understand that whole process. So now I'm going to talk about biotoxins, and we've had a lot of talk about biotoxins. Basically, most people have talked about the mycotoxins, but when you think about these people, I don't think that these patients are one type of patient. In other words, I don't think that it's one thing. I think that it's an accumulation. We're like huge reservoirs for toxins. We're like a toxic dumping ground as we go through our life. So toxic molds obviously release mycotoxins. You ingest them, you inhale them. We've talked about this all day. But this is what happens. And we know that in the Alzheimer's patients, we are actually finding that, you know, on autopsy. Especially when I talked about Finland. I mean, that's a huge problem there. The UK. In the UK, the number one cause of death for females is Alzheimer's. That's pretty amazing. Think about the UK. Think about the mold. Think about all of the moisture. I mean, I think that's a huge part of it. And by the way, in Europe, they've actually asked us to come over and train the physicians. Guess what we're not allowed to talk about? Toxins. Not at all. And we said, well, we're not going to come and do it the wrong way, so we're not coming. But yeah, so they're trying to work around it. You can't talk about toxins. You cannot. Mold is completely gone. Lyme is absolutely taboo. Hormones. No hormones. I feel so bad for the women in the UK. I mean, that really stinks. Yeah, no hormones. So it's a problem. Lyme disease is a biotoxin, and I'm sure that how many of you all treat patients with biotoxins? Does everybody treat Lyme? I know you do. But I mean, just show of hands. So few of you, but maybe not most of the crowd. And so Lyme, you've got the dinoflagellates. The world is a pretty toxic place. So these are common biotoxins. And interestingly enough, I'll wait for another slide to mention this about the algae. And basically, this just says the same thing. You know, this is talking about BMAA, which is a cyanobacterial neurotoxin causing ALS. And I think it's really interesting. When you look at patients with ALS, and I think Stephen Fry, I don't know if he's in here, but he mentioned this. He and I were talking about this yesterday. Most of those patients have had water activity, so they're very into water sports, and there's an algae that they're finding. So it's kind of interesting. I think a lot of this stuff, you know, we're looking at the same thing, and we're just looking at it in different lenses, through different lenses. Does anybody check HLA susceptibility? I do. I know a lot of people don't. A lot of people feel like the HLA susceptibility, whether it's there or not, it may not change what you do. And I would argue that in the Bredesen type patient or the cognitive patient, it's different. And I'll explain why. And then for those of you that don't know what it is, the HLA susceptibility is a genetic susceptibility to biotoxin illness. And it's believed that about 25% of the population has a genetic susceptibility, and 1% actually, I'm in that percentage, of course, is lucky enough to have what they call the dreaded gene. This gene means that you're susceptible to absolutely every biotoxin known to man. And I agree, I don't know that it makes a difference if you take a patient like me who is a wheezing hot mess with psoriatic arthritis. I mean, you could see what was wrong with me, you know? But when you get these cognitive patients, they don't really have any symptoms usually. They just can't think. So where do you start? And does it matter? I mean, would it make a difference to you if you knew that they had a multi-susceptible gene? Would it make you dig a little deeper? Would it make a difference? It might make a difference to their family, actually. And I think it's interesting too, certain individuals with one of the multi-susceptible genotypes, they have a huge problem with glutathione. So again, I'm going to say, so you think about Dr. Guilford's lecture, and you think about, you know, are we all saying the same thing just in a different way? Are we kind of looking at the same thing with a different lens? I think we probably are. And we're seeing varying degrees of illness with patients. These are the HLA types, and I've highlighted the multi-susceptible gene. And I think it's the 4353 that actually is the one that is related to glutathione dysfunction. I think the 11352B actually has been an association with connective tissue disorders. And so like your wingspan, if your wingspan is bigger than your body, then that's somebody you might look at Ehlers-Danlos. So now I'm going to talk about, I'm trying to tie this together, as you can see, in a different way. And I'm not really a Ritchie Shoemaker doctor. I don't want anybody to think that. But this is chronic inflammatory response syndrome. And so the key thing to focus on is a multi-symptom, multi-system caused by exposure to biotoxins or neurotoxins produced by a biologic source. And so basically a biotoxin is from a biologic source, right? And this is what Ritchie says: an acute and chronic systemic inflammatory response syndrome acquired following exposure to the interior environment of a water-damaged building with resident toxigenic organisms, including but not limited to fungi, bacteria, actinomycetes, and mycobacteria, as well as inflammagens, endotoxins, beta-glucans. You can read it. But basically, you know, what we're talking about with these buildings. And this is who Ritchie Shoemaker is. And I'm sure that everybody here is aware of who he is. But basically, this was his discovery from dinoflagellates. He had patients that were exposed to Pfiesteria. This is sort of a different approach. I doubt you've probably seen these two tied together, but they remind me of each other. So Richard Horowitz, so all the Lyme literate physicians here know, came up with MSIDS, so multi-system infectious disease syndrome. Symptoms caused a complex of Lyme disease, multiple tick-borne co-infections that encompass Borrelia burgdorferi, other bacterial, viral, parasitic, and fungal infections. And immune, inflammation, toxicity, mitochondrial dysfunction, they both have it. I would argue that these are very, very, very similar. Both are genomic, multi-symptom, multi-system, defective antigen presentation. And I don't think that we can argue that probably a big part of the reason these patients get so sick is they don't recognize it, which is a good argument for genetics in some form or fashion. And then the HLA susceptibility leading to dysregulation. So now I'm going to bring it back to the Alzheimer's because this is a big part of what influenced Dale Bredesen's protocol. And he definitely includes Shoemaker Labs because he feels like that's been a big part. We've been looking for biomarkers, trying to determine, how we can really tease these patients out and know which ones are which type and what we need to go after. Because again, you get somebody who's incredibly sick and they wait until they come in. I'm thinking of, I had a patient I sent to Dr. Dennis actually, and he performed surgery. Now I have her back. I've done one of Steve Fry's tests on her in a last ditch, or she's going to be dead. And she's 55 years old. So the story for her, they bought a very, very old farmhouse, 150 years old, and they bought this winery. And everything was great. She's an engineer. He's an engineer. 2 teenage children at home. And they went to go play a game of canasta, or one of those card games that they've played forever. And she didn't know how to play. And everybody kind of looked at her, and they were shocked, and they couldn't teach her. So that was the first time they really noticed anything, just out of the blue. And then the next thing that was noted, he retrospectively looked back and realized that she had been into this winemaking thing and had these guys come over, and she couldn't follow the conversation. So then she was evaluated, and she has early onset Alzheimer's. Profoundly, profoundly sick. And so does anybody know what a MoCA test is? Yes. Okay. So I did the MoCA test, for those of you that don't, is it's a Montreal cognitive assessment that we do in the office, and it takes probably 10 minutes at the most to administer. And the score goes from 0 to 30. 26 to 30 is considered normal. And the reality is that most of us in here, if one of us had 26, there's probably a big problem. So really, and it goes 26 to 30. Well, hers was 8. And I have plenty. I've had people that are 0, and they're doing fine today. But hers was 8, and we have been the gambit with her. When she came to me, a Lyme physician thought that she had Lyme, and the only thing that she had was a positive band 41. I didn't think that was enough to treat her with. She came to me on Doxy. This is really interesting. And we eventually took her off the Doxy, did the Bredesen protocol. She got better for a moment, and then she's gone down. There's a lot of factors here. Her husband decided that he, as an engineer, didn't feel that they needed to move out of the house, so he built a clean room attached to the house. That's a big problem. So I wasn't happy with that, and we got him out of the clean room, so I felt like she was still being exposed. They're in a questionably clean house now. But so now we've done this test on her, and I went back and retested Lyme. We've done IGeneX. I think she's had a DNA connection that was negative. We've really tried to kind of sift through everything. Because when these patients start going down again, I think it's important to start all over again. Look at everything and don't just assume that you know anything. And it came back, it's one of his tests that came back with funnel-formous mossae. It used to be globus mossae. What do you do with that? So it's kind of a fungal bacterial thing that he sees in all the chronically ill patients. And so now she's on doxycycline and itraconazole, which is what they've been treating it with. She's doing better. She actually realized that it was Father's Day and called her father-in-law, which hasn't happened in years, and wished him a happy Father's Day, so that was good. But she's a type 3, but when you look at this, she's being treated for all of this. So type 1 is going to be inflammatory, so if you're looking for type 1, you're going to look at all the inflammatory markers, the traditional ones, CRP, IL-6. And then glycotoxicity, well, what happens when you develop all these metabolic problems? You're going to develop some insulin resistance, and that's exactly what happened with her. But the trophic support is huge, and so we're looking at sex hormones. And when you look at people that have this whole, whatever you want to call it, SIRS, MSIDS, sick people, when you look at them, they get this dysregulation. So their sex hormones are always off. Her thyroid was off. Her glutathione was gone. So her reverse T3 was elevated. But also her cortisol was off. You just have to kind of think about everything. Vitamin D was low. Those are all the things that we look at with trophic support. And then for toxins, okay, so we know she had mycotoxins big time. The house tested positive for mycotoxins as well. She has heavy metals, and her Lyme test keeps coming back negative. So it's interesting, but these are the 5 types. And one of the things I have found to be amazingly helpful with type 3 is glutathione. I've used nebulized, IV, and I've promised Dr. Guilford we're going to try some oral, so we'll see. And then the vascular, we don't do as much with. We still put them on the protocol. The protocol works really. It's not hurting anybody to change their diet. And then traumatic, we're thinking about adding HBO, works very, very well. Stem cells are another thing I want to mention. I think that stem cells have a place here. I also think with the trophic, you do think about growth hormone. You get to a point where you have to kind of think this through. So Dr. Bredesen thinks about this like 36 holes in the roof. And if you think about it, if you can patch 6 holes, maybe if you patch the right ones, the rest are going to heal themselves. And it does work that way. The problem is we really don't know which ones. We just kind of are right now throwing everything up and hoping something sticks. And some patients respond really well and some don't. And we don't know why that is. For stem cells, I have patients who are really at end stage. They've been with me now for 2 years. You know, some of these people would probably already be dead. So if we're thinking that once we've sort of rebuilt their house, now it's time to give them stem cells. And I think the reason stem cells haven't always worked in the past is because you're trying to build the house while it's still burning, if you will. And so, yeah, that's the next step, I think, for some of my patients. Oops. ApoE genotype, I have to mention it. It is important. But I think your genes, all of our genes, are just not our destiny. They're just like the bullet in the chamber. And it's what you do with them, what you bathe them in, the exposures you have. Most type 3s are female. They're younger. They're an ApoE 3-3. That's not written in stone, but most of them are. And they're the ones that realize what's going on. So they have depression, anxiety. Most of them have visual spatial problems. Does anybody have any patients with posterior cortical atrophy? You do? Those are tough patients. I have a bunch of them, and they're really tough. And the crazy thing, they'll go and see the ophthalmologist, and their exam is normal, but they just can't see. And it's interesting. We're also doing a lot with macular degeneration, just throwing that out there. It has a lot to do with the indoor environment. So I'm going to talk a little more about type 3. Does anybody know what that is? That's cheese. Isn't that awful? Yeah. All right, so this is kind of reiterating a little bit of what I've already said, and I'll probably just end up reviewing another case in lieu of this, but they're the toxic ones, they're female, ApoE 3-3, Visual spatial deficit, I do a visual contrast study as well on these patients. And contrast really is more of a neurological test, and you can do it in the office or online. It's inexpensive, and it just makes it a little easier to kind of tease some of that out. We think that these patients are going to end up being about 85% of the population. Initially, it was thought to be 25 to 30. You know all that. So I'm going to give you a quick case about a patient. I was involved last year at the desert. We did an immersion program with Dr. Bredesen. We had 31 patients that came. And one of the women that came, her MoCA was a 0. She had not been verbal for 10 years. Yeah, and I think she's 79 right now. And her husband brought her. Her daughter is a pediatrician. They live in Virginia. And so looking at all of her stuff, and listening to the history, she's a 3-3, and her mother died of Alzheimer's. And it was so interesting. They were there for 4 days. We ate with these patients. We did neuropsych testing. We did all of the evaluation. And it was on the last evening that she walked up to me, and she smiled, and she said, "Isn't this lovely?" And I thought, "Oh my gosh, who are you?" And then she went somewhere else, and she introduced herself. We think that getting out of the house was a big part of this. We wondered. She'd been on a ketogenic diet while she was there. I can't think of anything else. I think she may have had some supplements, but we really didn't do anything else. So talking with her husband, when her mother died of Alzheimer's in Virginia, she was the primary caretaker. And she would go over there, and every time she would come home, her daughter and her husband and anybody else would say, "Wow, you smell so bad. You smell like Grandma's house." And so lo and behold, she had a ton of mycotoxins. I can't remember what her HLA is. What else did she have? But she had the mycotoxins. We tested the house. We looked at Lyme. We tried to look at everything. And today, and I wish I had put the video in my lecture, I just got a video from them. I get them all the time. She was kayaking. She rides a bike, and she emailed her daughter. Now, I'm not going to pretend like she's somebody that's emailing every day and texting. She's not. But she was able to get an email off and spell. She's reading children's books. That's huge. Think about what that gives this family. He's not going to have to watch her die in a nursing home. She'll never be perfect. I get that. I think that's a win, though, what we have right there. So it's interesting. We've talked about all this. I'm not going to rehash it. We've talked about a lot of the symptoms. I've lived those symptoms. They're very real. And basically, we have to remember the order of what we do things, I think, is really important with these patients. Let's see what my next slide is. When you think about these patients, you have to remember to go slow with some of them. You'll make them really sick. Dale's protocol has about 45 to 50 pills, and that's asking a lot of people. We put them on a ketogenic diet. They have to do mindfulness, they have to exercise, and there's ways that we do all of this to increase BDNF in the brain. So I think it's important to think about detox pathways. The reason I have this slide up is I think it's really important to think about this. Reduced MSH. Does anybody check these Shoemaker labs? I know I asked that, but all of them. So when your MSH is low, you get the dysregulation. And if you have MARCONs, you're not going to be able to get your MSH up until you get rid of the MARCONs. And that's really more of a colonization than it is an infection, but it lives in such a deep, heavy biofilm. And I think Dale believes that this creates brain permeability, all of the inflammation up in the sinuses. So it's interesting. And so the patients that I see don't get any of the symptoms on the left, really. They don't complain of GI issues every now and then. Sleep is plus or minus, but they have huge ACTH and cortisol dysregulation, huge ADH dysregulation. So they're drinking all the time and peeing all the time and staying dehydrated. It's kind of interesting. And then TGF beta 1, MMP9 are through the roof. Does anybody order C4A? Are you able to get an accurate one?
It's a problem.
It's a problem. It's not for you? Well, it has to go to Jewish National, and if it's not, I think it has to be in a -70 freezer immediately, and so it's just, I'm in Savannah, and people are pretty simple, and things don't always work right. So that's all I can say about that. I don't get it all the time anymore. I don't think that I can get an accurate one. So these are things, if you guys, so this is the crazy thing. I've been treating functional patients now for quite a few years, and I'm thinking about people that have cognitive problems, and I don't think that I ever thought of them in this light. Does that make sense? So, you know, you go back, when you start looking at this, you go back and you look at people. I mean, I have a very young guy, actually. I think Mark Philaday sent him to me to Savannah, and I think he may have even gone back to see Mark. I don't know if he has or not, but he wasn't getting better, but huge cognitive problems. And so it's just, you know, this is a different approach, but it seems to work because it brings it all more full circle. Because you can kind of get caught in a rat trap where you're looking at Lyme, or you're looking at mold, or you're working on viruses, and you don't look at the whole thing as much as you should sometimes. I think it's interesting. So the lab eval, we do Marcons. We basically do all of the cytokines, and I break it all down into different ways. We fix the nutritional problems. We optimize everything, so patients end up on a large amount of stuff. We have cognitive supporting herbs. We do quite a bit of Ayurvedic herbs as well. I'm using a lot of RG3 right now with my patients. It has better absorption. And, you know, for what it's worth, Dr. Pizzorno feels that you have to worry about whether or not they have mercury toxicity if you're going to give them IV glutathione, and I don't know about that. I've had some astounding things with IV glutathione. Had a young guy that came from Washington. I actually moved him into my neighborhood so that I could keep up with him for a little while, and his family came down and took shifts. He was single, which I think was a big issue for him because you don't have a spouse or anybody to help be your caretaker. And we gave him IV glutathione, and he spoke with word soup, and suddenly he goes, "How long have we been here? What time are we leaving?" It was crazy. It doesn't last long, but it works immediately. I've seen, you know, just as astounding with the gait thing, and a lot of my patients were ataxic. Most of them actually are. I always do a thorough neuro check, and I always check their gait as well. So this is the program in a nutshell, basically. We have them on a ketogenic diet with fasting. We fast from 12 hours for regular people, and if you have an ApoE3, 4, or 4, you actually need to fast longer. We push it to 16 all the way up to 18 hours. It increases autophagy, mitophagy, and it increases BDNF in the brain-derived neurotropic factor. And so that's the growth hormone for the brain. So the diet is challenging. We're not just a ketogenic diet, not the diet that can go out and eat a lot of cheese and do all of these things. We want a really clean diet. We more vegetable than protein, animal protein, and no grains, no dairy, no alcohol, no sugar. And we have them check their ketone levels and glucose levels. And some people do really well with it. For the people that lose too much weight, I get some of these women that get the dwindles with the low BMI. I use exogenous ketones. And what I do, I like to use the exogenous ketones initially in the morning, And if it's working, but they're not getting where they need to be, I do it in the evening as well. I don't think we should be doing it every day, so I do it about 4 or 5 days out of the week, and I give them a couple of days off. I think that that's been proven to help with ketogenesis. And when I do use the exogenous ketones, I'll give them more of the starchy vegetables like butternut squash and sweet potatoes, things like that. Brain training. Does anybody do that with their patients? Good, okay, excellent. And that's been proven as well, certainly is a huge help. Exercise, we like interval training. Seems that the interval training gives you the best boost in growth hormone as well as BDNF. And sleeping, obviously meditation. And then the rest of it is my job or the doctor's job to work on the rest of it. So it's a pretty complex program, if you can imagine. I spend about 3 hours with initial patients going through this. It takes a long time. I have a dietitian, health coach. They need a lot of support, lots of support. We do obtain quantitative imaging. I think it's important. We actually, Dr. Bredesen has a patient, you may have read about this, that had a hippocampal volume of 12%. And after using the program, and I think he was on VIP spray, it went up to the 75th percentile. This guy's a doctor. He had quit his practice, and he's now practicing on both coasts. So that's pretty significant, I think. So this is an interesting case. I received a call from a guy who called me up and said, I think I have Lyme, and I want you to treat me, but I can't come to your office. And I said, well, I don't do house calls. So he got his labs, but he never came. And his labs looked to me like he might even have mold toxicity. And so I called him back and talked about it with him, and he didn't believe it, and he works from home. So what happens to sick people when they live in a sick house? They stay home and get sicker. So it's just this vicious cycle. And so anyhow, I didn't hear from him, and I kind of, didn't think about it anymore. And this was what his labs looked like. All of his viral titers were elevated. CRP was very elevated, ESR was elevated, IL-6 was elevated, mycoplasma was positive, Marcons was negative, Lyme fluorescing structures. Now this is a really old test that I didn't do, okay? MMP9 was elevated, everything was off. And I told him he could definitely have Lyme, but he's been being treated for many, many years, and maybe you might think about mold. And he blew it off and said he couldn't come in, and that was that. So I get a phone call, and he calls up and he says, hey, I'm sending you my mom. I'm like, okay, what's going on with your mom? Well, she has Alzheimer's. I know you're working with Bredesen. I'm going to send her. So she comes in, sweet lady. She drove. She's pretty functional, but she definitely has Alzheimer's. And Mocha was 16. She was HLA positive for post-Lyme syndrome. And TGF-beta was 25,000. That's pretty high. Has anybody seen a TGF-beta a lot higher? How high? Wow, that's really high. Poor person. So an MMP9 is elevated. It should be less than 320. I felt like she might have Lyme, okay? But she gardens outside. She can't remember what she does. And I also felt that we did the mycotoxin test and it was positive. There's her Lyme test, positive, positive. There's her mycotoxin test. I can't read that. You probably can't either, but it's positive. So we gave her glutathione. I put her on antibiotics. We did Bredesen protocol as well. She was improving. She was reading. Things were getting better. And she got tired of coming. Apparently, she's pretty aware of her finances, and she felt like, she really didn't need to go to this doctor and do all this stuff. She's very happy at home. Then I get a phone call, and this is their picture. It's not a great picture, but their picture. And so the thing on the right is the wall that collapsed in. That's what they've been living in. So it's kind of crazy. I got them out of the house. They had an RV. It's not perfect. It never is perfect. They moved into the RV, which was small. I think it had dogs in it and all kinds of things. And they would kind of go in and out of the house. But today, at least, he gets off of the island. He's better. He had such vertigo he couldn't travel off the island. His mom is holding her own. I know I'm running out of time. And I'm not going to speak much about Lyme disease. I just think people have to think about it. That's all. Basically, it's a clinical diagnosis. This isn't about Lyme, really. But it's definitely a biotoxin, and it's definitely a big problem in our country and the world. This is interesting. I'm just going to mention this about that ALS I mentioned about the algae. So algal blooms, I think, are something to think about. I have patients who live in Florida, and I have some people that get really sick. Like if a red tide comes in, it's interesting. So I think of all of us as a bathtub. I think that we fill our tub up as we go through life. The drain is analogous to your genetics. And I think you have to think about that. You have to think about where you put your body and what your exposures are. We all have a tipping factor. And when I kind of think about when I'm undoing these patients, like I'm unraveling a ball of yarn, so to speak, or peeling back the layers of the onion, because you think about it, you know, something tipped them. I use a timeline. And when I look at the timeline, it's not even always about what it says. It's like a skyline. It's like everything's fine with your life, and all of a sudden you get this. I'm like, so what happened in 1986? And they're like, oh, I moved and got divorced and did this and did that. Stress is a huge driver. We all have a map, an inner map that we're born with. It's kind of our genetics, really. But to health or to being sick. Detoxing is huge. I think it's really important. I use a lot of sauna, glutathione, always checking for heavy metals and chelation. I think that's important. This is an article that just supports that in Finnish men, when they take saunas, they actually have shown to have less Alzheimer's. And this is kind of cool. This is a patient of mine. He is a pilot that has always flown back and forth to China. And, you know, aerotoxic syndrome is a big deal as well. And he had mold. And so anyhow, this is his sauna in his RV, because he no longer flies. He actually flies with cadets and teaches them, so he's doing great. All of his symptoms have reversed. All of his numbers have changed. And he was headed towards Alzheimer's. I would say that he was more MCI. So I just think when you have these patients, they're really complex. We all treat really sick, complex people. You have to go back when things aren't working and start over. Don't give up. Keep asking questions. And this is just 2 patients of mine that have completely reversed recently. One is the one in California. She's getting her license back. The other one is a psychiatrist in New York, and she's a Lyme patient. And she says she had mold. I didn't treat her for the mold, but I guess she might have. But she's doing great. Absolutely doing wonderful. And this is the last case. I probably overdid it with the cases. And this is my very first patient that I dealt with Dale, and we worked on it together. She came to me. She has a 1%, less than 1% hippocampal volume. She was a nurse practitioner. She knew that something was going wrong with her brain, which is really freaky if you can imagine having that happen. She worked with her husband in an orthopedic office, and she went around to all the doctors and said, I think, you know, something's happening. And everybody kind of blew her off, which is, I think, what happens way too often with these patients until they develop full-blown Alzheimer's. But her mother was dying at that time of Alzheimer's. Everybody thought it was her stress. And now, you know, she's in deep trouble. What we found Lyme. Her IGeneX was positive. They have a stucco house in South Carolina, and it was the bad one that wicks all the liquid up inside the walls. And so we've gotten her out of that, and this has now been over 2 years, and she's doing great. Her MoCA has gone from a 9 to, I think her last one was 21. She's not perfect, but she's functioning. She's at home. She has a happy life. Things are good. Every time there's a new exposure, before we discover it, she is like, goes right down where she started. It's kind of crazy.
Hi, my name is, my wife is, she is on the Bredesen protocol, Dr. Dale Bredesen's protocol for treatment of memory problems and problems of cognition. She's being treated by Dr. Mary Kay Ross. We've been in the program now for 1 year. It's been a complex program. We've identified 10 problems. Examples include elevated homocysteine levels, elevated glucose level, thyroid function abnormalities, and also Lyme disease, mold toxicity, multiple different issues. We've made some progress over the past year. Becky has improved. She's had improvement in her cognition. We've seen improvement in our laboratory studies. It's been difficult at times. For example, it took a while to get the vitamin D level back up. We had to figure out the correct dosage to bring her back into the range that she needed to be in. It took a good while to get the estrogen level back up. We tried multiple different techniques for giving the estrogen, and finally we're back to using a patch, which is working really well now. She's been on antibiotic therapy for Lyme disease, and also has babesia and is on a medication called Mepron for that. She's doing a daily strenuous exercise program. She's also doing meditation, brain HQ exercise, and has made significant progress with that. Feels about how she's making progress. She's worked really hard at this, and I'm really proud of her. She's done a great job with it.
All right, Becky.
I'm Becky Jones, his counterpart, and it's really been quite an experience. To begin with, I found that I couldn't really engage in what I needed to do because I was too anxious about the whole situation. But with time and with support from my husband, then I finally thought, well, it's time to get on board or either get off the train, you know. So, and we have, and a lot of it's been because I have him, and I don't know how anybody could do it if they didn't have somebody they could depend on to help them, because it's really hard to get through it. And I've actually talked with another couple who came through, and I can see her pain, and I want so much to help her with that. She's just not at the point where she's saying, hey, I've thought about this, I would like to talk to you. And hopefully that's what will happen. I'm happy to talk to anybody. I don't have all the answers. I don't think anybody does. But if I can help them in any way, with diet, with exercise, with sleep patterns, whatever is the best thing that they respond to, I will talk to them. I will meet up with them, because you do get better. It's really hard, and at the beginning you don't believe you'll ever get better, but you will get better. It takes a while to get 100%. I'm not 100%. Most people aren't 100% on a normal basis, but you know,
Close.
it's pretty close to being back to where I was. So I think that's the best thing to do, and people don't need to underestimate that, because I thought that way, and it's not. You do actually get better.
So I'm almost done. So basically then, we just have to keep turning over stones, and we have to keep working with these patients and try to see if we can always go back where we started whenever we're missing something or somebody is getting worse. And that's it. Thank you.